Hello and welcome to part 2 of the penetrating trauma to the chest, abdomen and extremities case from the case files emergency medicine book. So we stopped at the clinical approach and the initial management. Here there is a table about the identification of injuries in the chest and abdomen. So physical examination of the chest, auscultation for symmetry of breath sounds to identify hemo or pneumothorax, auscultate heart for muffled heart sounds, and assess for the presence of distended neck veins. These findings suggest pericardial tamponade, so assess for sucking chest wound. Further chest testing. Ultrasound evaluation of the heart is a reliable diagnostic study for cardiac tamponade. A chest X-ray may detect hemo or pneumothorax or free air under the diaphragm. Physical examination of the abdomen. Palpate abdomen for distension, the doughy feel of hemoperitoneum, peritoneal signs, or tenderness beyond the immediate site of the laceration may identify significant intra-abdominal injuries. So, palpate the abdomen for distension, for the doughy feel of hemoperitoneum, for peritoneal signs or tenderness beyond the immediate site of the laceration. These may identify significant intra-abdominal injuries. Further testing for the abdomen, chest X-ray and play abdominal films are not usually helpful. FAST examination for free fluid is fairly specific but may not be sensitive. Other options include observation with serial physical examination, computed tomography, local wound exploration, diagnostic peritoneal lavage, DPL, laparoscopy, and laparotomy. In general, gunshot wounds possess much greater injury potential than stab wounds because of the higher kinetic energy transfer to the tissue from bullets. When managing a patient with gunshot wounds, it is important to bear in mind that the bullet path and tissue destruction can be quite unpredictable, and it may not be assumed that the projectile has taken a direct path between the entrance and the exit wounds. So, now we speak about the specific anatomical regions of the injuries. Chest injuries. Generally, only 10% to 15% of patients with penetrating chest trauma require urgent operative intervention, while the remaining patients may require only observation, diagnostic imaging with or without tube thoracostomy. Fortunately, the majority of the patients requiring an operation can be identified within the first minutes by initial hemodynamic instability. So, the majority of the patients requiring an operation can be identified within the first minutes by initial hemodynamic instability, the presence of large hemothorax on chest X-ray, or high chest tube output. The chest X-ray has adequate sensitivity to evaluate for pneumothorax and hemothorax. However, roughly 15% of pneumothorax may present in a delayed fashion. Therefore, the absence of either should be confirmed by repeat chest X-ray in 3 to 4 hours. Obtaining an end expiratory film may increase the likelihood of detecting a small pneumothorax. CT of the chest is highly sensitive for the detection of pneumothorax. A small pneumothorax visualized by the CT and missed by the chest X-ray is referred to as an occult pneumothorax. These are re-evaluated by chest X-ray in 4 to 6 hours for progression. Local wound exploration of chest injury is not recommended because the procedure itself can penetrate the pleura and cause pneumothorax. Pneumo or hemothorax found by chest x-ray is treated by placement of a 36 or 40 French chest tube. The initial treatment of attention pneumothorax is often needle thoracostomy for faster relief of the pleural pressure, followed by the initial treatment of attention pneumothorax is often by needle thoracostomy for faster relief of the pleural pressure. Followed by immediate placement of a chest tube. Smaller tubes clot easily with blood and are not indicated in the setting of trauma. If the pneumo or hemothorax does not resolve on the post-placement chest XR, a second tube should be placed. Considerations for thoracotomy in the operating room include initial output of 1,500 milliliters of blood, or equal to 200 milliliters per hour over the next 5 hours. Any patient with an injury within the cardiac box should undergo prompt FAST, focused assessment sonogram for trauma. They should undergo prompt FAST examination of the heart by an experienced emergency medicine physician. The subxiphoid view may be complemented by a parasternal view and can detect pericardial blood with up to 100% sensitivity. Hemopericardium is an indication for pericardial exploration in the OR. Resuscitative thoracotomy is reserved for those patients who are in extremis or who have lost vital signs in the emergency department or within a few minutes prior to arrival. Both discussions and performance of this procedure can be associated with a great deal of controversy and emotion. It must be borne in mind in these situations, mortality exceeds 97%, and these interventions may expose the healthcare provider to unnecessary accidental injury and infectious agents. The best opportunity for a successful outcome is associated with procedures performed in properly selected patients by an experienced physician in a medical center with the capability to provide definitive treatment. The thoracoabdominal region. Thoracoabdominal wounds are of particular interest because injuries to the diaphragm are difficult to detect. And in the presence of negative intrathoracic pressure, herniation of intra-abdominal contents may eventually occur. Unless the diaphragmatic defect is large, herniation of stomach or intestines are rarely visualized by chest X-ray in the emergency department. Consultation from a surgeon should be obtained when diaphragmatic injury is suspected, because the definitive diagnostic study is surgical evaluation by laparoscopy or thoracoscopy. Anterior abdomen. Immediate indication for laparotomy includes clinical evidence of shock, which are hypotension, tachycardia, cold and clammy skin, or diaphoresis. Also, other indications for laparotomy are peritonitis, gunshot wounds with probable course through the abdominal cavity, or evisceration of abdominal contents. In the absence of these findings, further evaluation or observation is indicated. So, immediate indications for laparotomy are clinical evidence of shock, peritonitis, gunshot wounds with probable course through the abdominal cavity, and evisceration of abdominal content. Okay, so this is all for part 2 for the penetrating injuries case, and we'll continue inshallah in part 3. Thank you very much for listening. Do not forget to like, subscribe, and share.